Pancreatic cancer also, despite everything that we do for stage 4 cancers, the survival benefit is actually only 2 weeks, 2 to 3 weeks. So there's no point, like, why waste all that money? But esophageal cancers and colorectal cancers, definitely you should encourage your patients to get treatment, especially colon and rectal cancers have very good results. And risk factors, kind of all go similar, but I'll talk about esophageal and gastric together and colon and rectal together because they're kind of upper GI and lower GI. So esophageal and gastric is along with the head and neck cancer. So smoking, alcohol, iron deficiency, H. pylori. In Japan, they actually they made it a public initiative to kind of catch all the patients with H. pylori and treat them and see if the incidence of gastric cancer goes down, but it didn't. So still, you should treat these patients. High salt content in food, deficiency in micronutrients, use of smoked food, again, not very common in India, but consumption of large amount of red chilies, food at very high temperatures. And the symptoms are, of course, difficulty or pain in swallowing, pain in the shoulder blades, indigestion or acidity, fatigue, heartburn, and loss of appetite. And it is very, very easy to diagnose these patients with an upper GI endoscopy and biopsy. Treatment is usually combination treatment because they need surgery, they need chemotherapy, they need radiation therapy. Colon and rectal cancers, this is also becoming more and more common in India, and the reason I like to emphasize on this because this is something that we can do, we can screen for. We can encourage our patients to get either the colonoscopy every 10 years, or if they cannot afford a colonoscopy, just getting their simple stool occult blood every year is enough. I mean, a lot of patients, if they get that done, and only if it is positive, then you tell them, okay, go ahead and do a colonoscopy. So this is again a cancer that is diagnosed after 50, usually 50 to 55. There is a very important role of family history in this, first degree relatives or multiple generations having colon cancer. Consumption of saturated fat, diet and diet that is low in fiber can contribute to this. And again, an important thing that we always forget, patients with ulcerative colitis and Crohn's disease are at very high risk for colon cancer and should be appropriately counseled for this. The symptoms, it can depend depending on where the site of the tumor is. You can have change in bowel habits, you can have anemia, fatigue, they can present with bowel obstruction. If it's rectal cancer, usually it's more common that it presents you with bleeding. But early stage of cancers are usually asymptomatic, and that is where your colonoscopy or the stool occult blood test will pick up patients with early colon cancer. We already talked about the symptoms, and this is like a very advanced case where you have multiple deposits in the liver. So I've already touched upon screening, but your postmenopausal woman should really be counseled about screening for colon cancer. It should be done in women who are over the age of 50, but if they have a family history of colon cancer, then you need to tell them to get it done earlier. Usually we say 10 years before the age that the relative was diagnosed at. How do you examine them? A colonoscopy or colonoscopy can be done every 10 years unless it is abnormal, and more frequently depending on what abnormality was found in the colonoscopy. A stool occult blood test is annual. If they get a flexible sigmoidoscopy, then that needs to be repeated every 5 years. The treatment is usually surgery if it's diagnosed early enough and followed by adjuvant chemotherapy. Rectal cancer, though, we include radiation therapy as part of the protocol for treatment. So I only focused on a little bit of cancer because these are the ones that we see more as we're growing older, and these are the ones that are more common. But you have to understand that one person cannot treat cancer, and it is a very team-based approach where you need your surgical oncologist, you need your radiation oncologist, you need your medical oncologist, your pathologists, who are the most important in my mind because they're the ones who tell me what malignancy it is. And of course, one cannot do without a really good nursing and paraclinical staff. And again, we should encourage our patients to get a treatment where you can get everything all together. I don't think I need to focus on this. I have a little bit about radiation and chemotherapy. But coming to my last slide, how can you decrease your cancer risk and your patient's cancer risk? You should counsel them, of course, about smoking. You should encourage them to stay at a healthy weight, and I think Auntie is the one that we should follow, and she really advocates it. They need to get moving and get regular physical activity. It's not just enough daily routine, you really should have at least 30 minutes of that, moderate, I would say.
Let's say we all promise to do it. We all promise to do it.
Yeah.
To reduce the risk of cancer.
Yeah.
Yes.
Pledge. And of course, things that our grandmother always told us: eat healthy diet, with plenty of fruits and vegetables and less saturated fat. Limit your alcohol. Protect your skin, and especially know your family history, because if there is a family history of breast cancer or ovarian cancer or colon cancer, I mean, those are the patients that we really need to focus upon to prevent the occurrence of those cancers, considering that we've already got a signal, that this family, that these problems can occur. Regular checkups. Really encourage our postmenopausal women to come for regular checkups, even if they don't come 3 monthly, 6 monthly or annual, whatever they can afford and whatever is feasible for them. And immunization, not for your postmenopausal patients, but maybe they can counsel their community and their relatives and people that they know to get the immunization for especially cervical cancer vaccination. So with that, I'd like to stop, and I'd like to thank everybody and welcome more questions. Where women fast for their husbands, but they should get their husband in for a health checkup.
Yes.
More than fasting for them.
Yes. Because, most of the time I advocate it because they are the only earning member in the family, in majority of the, families. है ना, करवा चौथ पे सबकी पूजा होती है, अगर उनका उस दिन हेल्थ चेकअप हो जाए हस्बैंड्स का, तो नथिंग टू बीट दैट. डॉक्टर साहब, am I right? Husbands are totally neglected people. It's only in the corporates, in army or in police, they have a regular checkup, but otherwise there's nothing, and they're the only earning member. I think something good idea. Thank you so much.
No, I don't think so. I mean, and I'm not a surgeon, but unless they're simple, not all gallbladder stones are going to, end up as malignancy. But yes, of course, there is a chance. I would leave that answer for the surgeon, but not all gallbladder stones are going to cause malignancy. And actually, there's another very interesting corollary. We always think as Barrett's esophagus as being really bad and it will lead to cancer, but actually the incidence is not that high. It's just that those patients, you need to follow them more closely because they get dysplasia. But cervical dysplasia, of course, definitely has to be managed.
Incidence is more.
Yeah,
That is why it is referred
to get it out.
Yeah,
but it's
and
not.
India, the incidence is more.
But infertile. Actually, I agree with you. I mean, I've seen a lot of women with gallbladders. And actually, the thing is that they have undergone the surgery, the majority of them.
That's
but because they haven't had the,
yeah,
they haven't had the
paternal history also now have 2 patients and both have history on the paternal side.
Well, actually, it is less important. That's what we have. I mean, that's the textbook answer. That it's your maternal history that drives it.
One more question.
Dr. Sujit,
Like this vaginal drying is there with this chemotherapy for your breast cancer. What non-hormonal moisturizer, what do you advocate?
anything
That I
little
would
outer. Anything.
very specific.
Vaginal moisturizers market में है.
Which
Even Eastern cream should do that.
very well, and the topic was really very informative and innovative. Thanks to Dr. Alima once again. Give her a big clap. Now I request Dr. Amita Sharma to please give bouquet to chairperson. Now I request Dr. Shalini Paul to give bouquet to Dr. Now I request Dr. Sujit from Nakoda to present bouquet to Dr. Chitra Gupta.
We'll have a second session, and the topic is oral anti-diabetes in the management of type 2 diabetes, initiation and stabilization of type 2 diabetes. And this eminent speaker is Dr. Amit Mahajan, who is a clinical diabetologist, Tagore Hospital. And the chairpersons, chair the session, I invite Dr. Kamal Gupta, Dr. Amita Sharma, and Dr. H.Q. Obera.
Investigation and stabilization of type 2 diabetes.
I'll be talking about management of type 2 diabetes. As fast as cancer. And diabetes has now become today diseases. But premenopausal women with diabetes loses that protection. And women in general, it has been seen that they receive less medical aid and have worse survival. A woman admitted with acute myocardial infarction in a hospital has a worse survival than a male counterpart. So that's why the management of diabetes not only a physician's job, but every doctor should know that. How to diagnose diabetes? Fasting plasma glucose is the preferred test to diagnose diabetes. Till last year, HbA1c was said that it is not a good marker for diabetes, for diagnosis of diabetes. It is only for monitoring of diabetes. But since late 2011, they have said that HbA1c is also can also be used in the diagnosis of diabetes. So how do you diagnose diabetes? If fasting plasma glucose is more than 126 milligram per deciliter twice, or a 2-hour oral glucose tolerance test more than 126 is diabetes, and less than 100 is no diabetes, and 100 to 125 is that in between range. And these patients who have the glucose fasting in this range have a 40% risk of developing diabetes over the next 5 years. And impaired glucose tolerance is a 2-hour OGTT more than between 140 and 200. And these patients also, like IFG patients, have a increased 40% risk of developing diabetes over the next 5 years. So, in whom we should do screening for diabetes? All patients over the age of 45 years. And it should, if normal, it should be repeated every year. But 45 years only in those who have no family history, not hypertensive. If you have family history, if you have hypertension, high cholesterol, macrosomia. So to avoid all these things, pre-pregnancy planning is very important in diabetic women who are of childbearing age. And similarly, postpartum planning is also very important. After most patients who develop GDM become normoglycemic after the delivery. But some patients do retain the higher glucose levels. So in those patients, you have to plan during lactation and after lactation how to manage diabetes. Diabetic women have higher incidence of genital urinary infections, higher incidence of complications of diabetes in postmenopausal women. After menopause, the age advances. As the age advances, the complications of diabetes also advance. So these are the few points we have to keep in mind when we are seeing a woman with diabetes. So before we start writing a drug for diabetes, or before we start treating diabetes, we must first evaluate few other things other than fasting plasma glucose, which go along with diabetes management. One of the most important things is the blood pressure. Any diabetic woman, any woman who is diagnosed with diabetes, you must check the blood pressure. Fundoscopic examination, the effect of diabetes on eyes, everyone knows. Blindness is the leading cause of death, also cause of blindness. So, to prevent the retinopathy, we must all do a fundoscopic examination of any woman who is diagnosed with diabetes. Foot examination is very important. Diabetes causes a lot of neuropathy, foot ulcers, and non-healing ulcers. And peripheral pulses must be checked because of peripheral vascular disease in diabetics. We must check for ankle reflexes again to prevent neuropathy and vibration and monofilament sensations. And apart from doing fasting, postprandial and HbA1c, these are the other important tests which must be done in all diabetics who are initially diagnosed and every 6 months after that. And most important among them is the lipid profile. High cholesterol levels with diabetes is an invitation to stroke or cardiovascular disease and others. Creatinine, we all know the effects of diabetes on the kidney. HbA1c, microalbuminuria is an important test. It can tell you very early whether nephropathy is developing or not. Liver function test, because there are certain drugs in treatment of diabetes which must be reduced in dosage or stopped if liver function tests are elevated. And since diabetes is also an autoimmune disease, so thyroid must be checked, especially in females. So what are the goals of treatment? We must know the goals before we start treatment. So HbA1c should be brought to less than 7. The latest guideline says it should be brought to less than 6.5. But usually it is seen that when we try to bring it to less than 7, the risk of hypoglycemia is high. So we must explain the risk of hypoglycemia to the patient, because that is also very dangerous. Fasting, we must bring it down to around 100. Postprandial less than 180, BP to less than 130/80. LDL cholesterol should be less than 100, and triglycerides to less than 150. And HDL must be brought above 40. And there are separate drugs for each and everything, which I will be discussing. Gestational diabetes, I think we have another lecture, so I will not touch on that. HbA1c, what is HbA1c? HbA1c is average of your 3 months glucose. So it should ideally be tested every 3 months. And there's a 35-point gap between the various 1% of HbA1c. So 7 HbA1c roughly means a mean glucose of 170. And with every percentage rise and decrease, there's a 35-point rise and decrease in the mean glucose. So if you have a HbA1c of 10, then your average mean glucose is around 275. There's one very important thing which we must keep in mind. In India, as Anubha said, that the cancers are detected very late. So diabetes is also sometimes and mostly detected very late. So most of the patients with type 2 diabetes have complications at the time of diabetes. So don't just check the glucose, check for all the complications of diabetes, whether it is retinopathy, neuropathy, nephropathy, and cardiovascular disease. So what are the complications which we must keep in mind? The acute ones are the decay and the non-ketotic hyperosmolar state. These are the acute complications, but in freshly diagnosed diabetes, we must look for retinopathy, neuropathy, coronary artery disease, peripheral vascular disease, and risk of stroke. A very common and a very underdiagnosed